That's fine as well. Okay. So first thing you do is observation, right? You're really looking for muscle gripping, and the person is an anti-pelvic tilt, not an impulsive pelvic tilt. General sense of idea. Right? Then you do your palpation. I'm gonna say that for last, because that's most complicated, right? Then you do your range of motion. So you guys done range of motion before. It's pretty straightforward, right? So can you bend forward, touch your toes? Okay. And your biggest thing is you're seeing what willingness to move. Does it hurt? Right? And then what do you do at the very end there? A little overpressure, and push it into my hand here. Good. What's that do for? Yep. So if the person had pain going forward, right, and radiating pain, which two diagnoses do you think it is? Herniated disc or piriformis, right? If they bend forward and have pain and no radiating pain, you're thinking sprain, strain, right? So then, how you differentiate between sprain and strain? You do this. Push up, right? That would hurt with what? With strain. Overpressure will hurt with both of them because you're stressing both. Okay? So you see that, how easy it is, right? Bending forward, because you're radiating, okay? And when you bend forward, if they have no pain, what do? Have them bend forward again. Bend forward a few times, all right? What's your goal? Try to what? Reproduce the pain, right? Up to 10 times, right? So that's a bend forward phenomenon, all right? Bend backwards, same thing. You bend backwards like this, okay? This one, we don't give overpressure, all right? Because why? You're slamming the spinous process like that, right? So bend forward, push into my hand, all right? And I don't think it ever gets the abdominal strain, but hey, for the sake of being thorough, that's why we do that, okay? And then we also add side bending. Why do we add side bending? Why would we combine motion?
Flex, or you need flex, or
Right? So your whole goal is to stress, right? So if that's a facet over here that may be sensitive, right? Right? How do I stress it? Bending backwards and to the side, right? I have to what? Double stress it. Yeah, I'm stressing it, but how can I stress it fully? Adding side bending. Also, when you do this, what happens to those holes? They close, right? Does it close with extension? Yeah, but it close a lot more with extension and side bending. All right, so this is why we do the combined motions. Okay. So then, bend up and back here, and then come to the side here, and then come to the side there. Yeah? And you see what I'm doing here? I'm guiding him. A lot of people, what are you talking about? But no, just go that way for me, please. Good. This way for me. Good. Bend forward. Bend forward, touch your toes. Here. Then go to the side. The problem is when you go to the side, some people do what? Do a hip rotation. That's why sometimes you have to block the pelvis. Good. And go the other way. Okay? If not, you're just testing the hips. That's straightforward. That's good old-fashioned range of motion. Later, we'll do the H&I testing stuff. That's more complicated. And then we do S1 testing. So you turn around. Hold on to this chair. Face across there. Face okay. Pick up your left leg up. Okay. And then you go in tippy toes 20 times. Okay. What's normal? 20 times without compensating. A lot of people, when they compensate.
Is he even doing a full heel? What is half? I don't think you're doing a full heel raise. Oh.
Can't do it.
Yeah, I was gonna say, so wouldn't we just stop it and be like, he's not doing a full, or no?
Well, he's doing it.
Okay.
I mean, as long as the arch goes up, right?
Okay.
Yeah, he has some foot stuff going on, right? But a lot of people will cheat. They would do like an extension thrust. They bend the knee and use the knee quads to pump stuff up. Okay. You have to test this one because we keep talking about what? Fatigue and weakness, right? Because if you do this, take a seat, please. Class here. Put here. Push down. And if you resist this way, here, push down. All right? No, stay there. Push down. Stay there.
Oh.
There you go. When you do this, and if a person can resist you, maximum force, what grade is this?
No, that's not against 3.
No, it's a 2+. So you doing this is not the same as standing. and you're gonna what? Miss out on myotone dysfunction, and your whole goal when you're seeing a patient is making sure they don't get worse on you, right? So you have to make sure you screen that out. Okay? And okay, so that you do for both legs. Okay? All right, the palpation part. I know this is the hardest part, so I say this for last. Normally this would be second. Okay, so oh, I was sweaty. Yeah. There you go. Okay. I do this all the time on patients too. I say, you're a little bit sweaty here. I want to stop. Okay. Okay. All right. So remember, the 3 categories, all right, of palpation. Right? We are palpating for tenderness. Why do we do tenderness? Tells you what structure is damaged. Okay? Then we palpate for muscle guarding. Right? Once again, why do we do that? It tells you what motions they're trying to stop and what ligaments, remember the muscles attached to the ligaments, are probably affected, right? And the third thing we palpate for is for positioning, right? So is spinous process, equal spacing, is this like this, it's like this. And why do we do that? That's more later for the pathomechanical and driver stuff, okay? So we'll keep it simple. First, let's palpate for tenderness, okay? So I think the best way to do this, okay, grab that spine right here. I'll do a side-by-side comparison. Okay, we have another one of these, right? Let's do a side-by-side here. Hey, you guys come up. You guys can be my like Vanna Whites on the side. Okay? Okay. You just pop it while I'm popping, okay?
Is it really?
Alright. So the first thing, right? When you do this, right, you're gonna be overwhelmed. Right? Whenever you learn a whole bunch of different techniques, remember, I'm a big fan of the systematic approach. So sometimes it's easier to work with your head down, right? And I'm gonna do first category. I'm looking for what? This tenderness, right? So I'm going in between the spinous process. Okay, Vanna Whites. You guys know what Vanna White is, by the way?
No.
Oh, okay, all right.
No.
Wheel of Fortune. Obviously, you're more educated than Vanna White.
Why does everyone know her name?
Okay. So what you
It's
do?
like the complex.
You palpate the interspinous space, okay? And you see what we're doing there, right? We're going to each one, for 2 reasons. Number 1, there's a ligament that goes there, right? Which ligament? Supraspinous, right? So if it's tender, it tells you what? It's overstretched. Oh, by the way, as we're doing this, grab your spines.
I can stare at it.
And move my spine, I'm borrowing my spine back.
It's weird to me.
Oh, really?
I know. I think it shows up. It hurts more when I have like. What a chiropractor, right? But they something should have just gave it to me. Right where that is.
Okay. So, right? Remember, right? One of the key things for learning, right, is try to create multiple synapses for learning, right? So when you are reading, you are using one part of your brain, right? When you are reading and you are talking out loud, you're also using 2 parts of your brain. And if you're reading and you're talking and you're actually doing, you're using another part of your brain, okay? So this is why I always strongly suggest when you're practicing, right, pretend there's somebody in front of you. And I don't want you to pretend, this is why I want you guys to get the spine model. I want you guys to actually, when you're studying, read it, talk out loud as you do it on your spine model, okay? This is how you get a deeper understanding, and it makes studying much more interesting than reading notes, okay? So that being said, so, interspinous spaces, right? And it's feeling. I'm feeling for what? Tenderness, okay? So Sam, any tenderness? Nope. Okay. And I'm looking for space. Okay, so in this case here, right? Good space here. But sometimes you get somebody like this, and you can't get in between the space. Okay? So that means what? That segment is stuck in flexion or extension?
Extension.
Okay, so it's in extension, not stuck. We'll find out stuck later, right? Okay? Straightforward? Yeah, alright. So it tells me positionally where it could be in, and if that ligament is sprained. Okay? The next part you don't have to know, but for you spine nerds there too, right? If you touch it, right, and you can't feel any space, and it's tender, it can't be a ligament, because you're not touching the ligament, and the ligament is not on stretch. Instead, what you're getting is an arthritic response, right? You're getting a low sensitive spinous process by touching. All right, so you do that, then you work with your L5. L5 is what? Smaller. And then what I do? I go this way, and I go this way. Okay?
Just on each side of it.
Each side of it, okay? And if it's tender, right? Or it's guarded. And Sam, it feels fine, right?
Because that's ilial.
Ilial lumbar ligament.
Yeah.
Yep.
It's okay to use your thumbs when palpating.
Yep. Yeah. Why? Is there otherwise?
No, I just because I know it's like don't use thumbs, don't use the thumbs. It's kind of
No, you don't want to use your thumbs in a hyperextended state, like this. Graciela, what are you doing in my classroom? You want to learn spine again? Huh? Dr. D! Dr. D, this is not neuro class. Alright. Oh, okay. You know I'm coming by your classroom later, you know that now. You just started something you can't finish. Alright, so still palpating for ligaments, right? The big one is the PSIS, right? If you go medial, the PSIS, okay? Right? If you go medial to that, that's a sacrotuberous ligament, sort of, right?
medial.
Yeah, it was hard because the rectus spinal muscle attaches to here. So it's questionable whether you get palpated or not. But the key thing is really the inferior to the PSIS. That's the long dorsal ligament, okay? And its job is to stop contour-nutation, okay? Stop contour-nutation. So I always remember the acronym LIC, right? Long dorsal goes under, stops contour-nutation. In the video I said it backwards. This is the thing I said backwards. Yep.
Are you strumming it vertically?
Oh, good question. What am I doing? I'm just palpating it. See if it's tender.
Okay.
Okay. So later when we get into the pelvis stuff, right? The sacrum is over here, right? We don't want to be one side like this, right? We call it a contour-nutated sacrum or a backward sacral torsion. This is awful for that.
When it's doing this, you're like something like this,
This
or it's doing side. Oh, this way.
Yeah,
like,
it's rotating one
like,
side.
Got it.
So if you're rotating, you're nutating one side, you're contour-nutating one side, right? So this, if you do this, what are you doing? You're pulling on ligaments and stuff like that. So you're, once again, review into spine and space, see if it's tender, see if it's compressed or too open. Either the lumbar ligament, right? If it's tender, it tells you what? L5 is what? Translate it. And then I'll palpate the inferior to PSIS. If it's tender, the sacrum is maybe doing what? Contour-nutated. There you go. So you see that? You are what? You're thinking as you're going on. Because if I feel that it's a spine and space tender, too much extension or flexion? Too much flexion. If I feel this is tender, I'm thinking too much what? Anterior translation. If I feel tender over here, I'm thinking what? Too much contour-nutation. You see that? That's thinking as you're going. Because later, you want to see if it makes sense with the other part of the examination. Yep.
That's for both sacrotuberous and long dorsal?
No, sacrotuberous stops nutation. The reason why I haven't stressed it so much is kind of hard, right? The rectus spinal muscle, like I said, goes right here too, which kind of makes sense because the rectus spinal muscle also brings you to nutation. So it helps you stop contour-nutating.
So you have to like dig like.
Yeah, it's
like
hard to
under
dig
there.
versus standing because the muscle's on.
Okay.
Okay, everybody good in that part, okay? Remember, our jobs here are not to be robots, right? Our jobs is to what? Think, right? Because before we've done this, we would have done a what? A subjective. does this make sense? The person has pain with flexion. I think this is it. I think this is it. I think this is it. Okay? Okay, so after I palpate for the tenderness, I palpate for the muscles. And that's easy. Right spine muscles, or your big, thick muscles over here. And your QLs, you just come through the side. Okay? And your butt muscles, you just palpate. Okay? And why do we palpate the right spine muscles? If it's hypertonic, it's trying to stop what? Flexion. It goes to stop extension by being really rigid, right? But it's just stopping what? Spine motion. QL is trying to stop spine motion, but in particular L5. And then any butt muscles tight is trying to stop SI motion or hip motion.
Should you piriformis with the glute too, or would that be better?
It's part of the glutes.
Okay.
Right? We'll keep it simple right now. Okay? So that's why we palpate it. It tells us why is the SI trying to be stopped? Why is it trying to stop the lower back? Okay? Okay, yep.
Why does the QL specifically try to stop L5 motion? Because isn't it attached to all lumbar processes?
Oh, but remember it has a ligament that attaches to iliolumbar ligament. That's how. So you're right, it can be rested down, that's right.
Oh, and L5 is iliolumbar.
Yeah.
So then, okay.
Okay. So other positioning from other semester. Hip, does it feel anterior translated? Hip, does it feel anterior translated? Rings, do I feel anything that's popping up? Okay? So I'm gonna go over that again, okay? Alright. Here comes the hard part, alright? The hard part is really what is the sacrum doing, what is the pelvis doing. So we already mentioned before, the sacrum, we don't want it to be what? Rotated, okay? So actually, I have this pelvis here, look at this. The biggest difference between my pelvis versus yours, a lot more expensive than yours, because mine could do this, alright? All your sacrums don't articulate, I spend extra money for this stupid articulation thing, okay?
Rubber bands.
Yeah, the rubber bands, I know, right? So anyways, right? This is the sacrum over here, right? The biggest thing we're looking for right now, we're checking for this rotation. Actually, no, let's do the ilium first, okay? So right now, the iliums are the iliums, right? They're level, right? So we can have this phenomena anteriorly rotated. So we go into this. Alright. You can be anteriorly rotated, it could be posteriorly rotated, or you can have a up slip or a down slip. Okay? So these are the big four. Up, down, anteriorly rotated, posteriorly rotated. Yep.
Can you ever see a bilateral up slip or down slip?
Whoa. I doubt it because when we talk later about up slips are usually more traumatic in nature. You land on one leg, and by you landing on one leg, you drive the pelvis up forward. Yep.
How do you differentiate it? How does it upslip or
Very good. Right, and that's the $1 million question. So if you are anteriorly rotated this way, how do you know is it really anteriorly rotated or this guy here is posteriorly rotated? And later we're going to talk about it when we do our
You
motion.
check down the chain.
Huh? Well, before we do that, that's a good question. But we're going to just work on basics first. How do we know if you like this? Okay, and it's simple. All we do is palpate this PSIS. Okay, this PSIS, right? If it's up, right, and the ASIS is down, that tells you what? You have to rotate it. If you have the other way around, if this is up and this is down, posteriorly rotated. Yeah.
Does this just get better like everything else? The more, I mean, it's because sometimes I feel
Oh,
like it's
we're going
hard
to talk about that right now.
Okay.
Yeah, see, that's good. But the big thing is, the $1 million question is, how do I tell? And the way we tell is by using your thumbs, which I'll show you in a second, and we're going to figure out whether you're here or you're over here. Every person has something, right? But later we'll talk about if it's significant or not. So, if you have this, right, you have to touch the PSIS. When you touch the PSIS, you don't touch it anywhere, right? Because, right, this is the PSIS over here, right? If you touch it over here versus touching it underneath it versus touching on top of it, it's all what? Different, right? Let's say I touch the top one here and I touch the bottom part over here, I'm going to think the person's what? Uneven, right? So the key is to do what? make sure you hook underneath both heads. When you do the ASIS later, you make sure you hook underneath both heads. Okay, that's number one. Number two, you have to get an eye level, right? Because when you're looking at things from too top to bottom, it's going to throw off your visual perception. So you have to be at eye level. Okay. Number three, right? You're going to have to use before you make a decision, feel it first and see does it match what you see. Okay. This, by the way, has horrible interrelated reliability. It's like worse than guessing, right? Right. So this is why I'm gonna show you guys something right now. Okay. So, okay. Remember, if it's crooked, right? Whoa, right? If it's crooked, it's gonna affect spine motion. Okay. So what I'm doing over here, right? So,
So you're clicking.
and what do you guys think? Which one's higher? Left. Okay, so that's your hypothesis, right? So can you bend forward for me? Let's see how far it goes. And you get just touch the floor, right? Okay, come back up. So if the left one is higher, right? We'll talk about ASIS in a second. Now the right one's lower. Yeah, right? That means is he doing this or is he doing this? A or B? A. Right? So if I were to correct it, what should happen? It should feel better, right? And if I uncorrect it and actually jam it more, it will get what? Worse. So you understand the concept here? Okay? You have the hypothesis, which is higher, which is lower. So what I'm going to do, I'm going to actually what? Make it worse. Right? Let's see.
And you would have what, a decrease, right? More pain or less
Well,
motion?
yeah, you're going to get a decrease in motion because you're what? You're increasing the dysfunction further. So I'm here, that's what I did here. I just do this. Bend, step, bend forward. See? That's it. Come back up.
Got it.
So you guys were half right. We're not sure yet. Now I'm going to do the opposite. Go ahead. Bend
So
forward.
now you're correcting.
Now I'm correcting. There you go.
Oh, yeah. Okay.
Okay? That's how you tell. All you guys are going to ask me, Dr. E, I'm not sure. I'm like, could you test it? Okay? That's how you know whether the person, you're correct in your synopsis. Very important, because later we'll learn how to treat the pelvis, and you have to know if it's anteriorly rotated or posteriorly rotated. Now, the other question somebody asked, right? How do I know that this guy is going too far forward, or this guy is too far back? Okay? So, I have both my hands on underneath the PSIs, bend forward, touch your toes, okay? Which side goes higher as he bends forward? The left, okay? So the way it works, when you bend forward, the dysfunctional side will go higher. I'll say it one more time. The dysfunctional side will go higher. I'll explain the why in a second, but so if his left side was higher, I'm thinking he's anteriorly rotated. Right side, I'm thinking posteriorly rotated, right? So if the left side gets worse, I think he has a what? An anterior rotation. If his right side went up, I'm thinking he had a posterior rotation. Okay? Most of the time, it's an anterior rotation. Jenny, don't hit yourself in the spine. Alright. So that, right? Most of the time, it's anterior rotation. Okay? Yeah? So, like, you put this and move us, right? Look at you guys with your stiff pelvises, right? So this is anterior rotation, and this is posterior rotation, right? There's a little structure right here, right, that stops you from posteriorly rotating. Okay? So it's very hard to posteriorly rotate. Insidiously, yes, dramatically, if you're in a car accident, you can get a posterior rotation. So most patients have an anterior rotation dysfunction, unless there's a trauma. So when you think it's posterior rotation, probably might be incorrect, okay? Unless there's a history of trauma. Okay, now why? Why is it when I bend forward, the side of dysfunction goes up? Okay? So when you're bending forward, imagine this, there's a spine here. You're bending forward, right? The weight of the spine brings your sacrum what? To nutation, right? And then it contra-nutates, which we'll talk about later, right? Right? Then what happens? The pelvis follows. Okay? So the first part, the sacrum is doing what? It's going up and over. But if you're stuck in anterior rotation or posterior rotation, that means you're what? You're stuck. So when you go forward over here, because you're stuck here, it's going to bring it with you. Right? And this is why the side that moves up and forward is the dysfunctional side. So I'm going to say it again. Right? If you're either anteriorly rotated or you're posteriorly rotated, right? That means you have hypermobility, whether it's capsule, muscle, ligament, whatever, right? So when the sacrum goes up and forward, you should be able to what? Dissociate, right? But because you're stiff here, it brings it with you. So the side that goes up and over is the dysfunctional side. Okay? So that's the PSIS. You do the same thing for the ASIS, okay? ASIS is come forward, right? And you pop it, you do the same thing, okay? You flexing to them? What's going on? No, yeah?
No, the hand always is half pulling us back.
Bend forward. So you do the same thing going in the back, same thing going forward, okay? Now, when you get better, you don't actually, I don't go in front in the ASIS anymore, I just feel it, and I stop right there. So that's the pelvis. So if this side is higher, and this side is lower, we're thinking what? Anterior rotation. If this side is lower, if this side is higher, you're thinking what? Right? If this side is higher, and this side is higher, upslip. This side is lower, this side is lower, dowslip. Okay? You rarely get dowslips, right? Yeah.
So now let's say is that the case? You know, when you bend up, when you bend forward, up and over, does that work for posterior?
Up and over?
You know, when you bend forward and then whatever one goes up and over, that's the side of dysfunction. But let's say it's like we were palpating Stan, and his left was higher than the right.
Left is higher than the right.
Right, the PSIS is just before we had him bend forward.
Yeah.
Let's say it was actually a posterior translation of the right side.
Yeah.
Would the right then go up and over? Okay.
You get stuck to it. Okay.
Or would it be even? Like would you?
No, it would be more in relationship to the other side. Okay, so that's the pelvis, right? The next thing you have to do is the sacrum. So it's very simple, right? Here's PSIS, plus sacrum. And you just ask yourself, does one side feel more prominent versus the other? Right? So I think you said something one time, right? Do you feel like this or do you feel like this? Okay? Pretty straightforward. What you do is pick thumb here, and you see if it's more prominent. Okay? But if you look at the pre-reading, I'm sure you guys are confused with this, because sometimes when this happens, is if you feel a rotation, is this happening because it's following the ilium, or is it because it's independent? Right? So what do I mean? Right? So if you feel this rotation like this, right? Is it because it's just following what the pelvis is doing? When I move a pelvis, what happens to the sacrum? It rotates, right? Normal. So when you feel a backward motion here, this side is still supposed to be rotating posteriorly or anteriorly? Posteriorly. Right? Posteriorly. Right. However, some people, the sacrum does the opposite. Right? So this side is anteriorly rotated, and this side is more rotated that way. So that's not natural. We call that unphysiological rotation. This is physiological, it's following. This is unphysiological. Make sense? Yeah. Okay? So how do you tell if it's unphysiological? It's simple, because we already palpated the ilium and already determined whether it's anteriorly or posteriorly. So if it's anteriorly rotated and this is rotated to the right, then unphysiological. If it's posteriorly rotated and this is rotated to the right, I think it's physiological. Okay. See, aren't you guys glad you guys read the readings first? Because it was really, really confusing. And for those who didn't do the reading, now you're probably totally lost right now, right? I went kind of faster because I explained it there, right? So, ready? This is in a normal speed. Okay, ready? Actually, let me do this to somebody who actually has pain. Chris, oh no, listen, you're recording. You must have pain. Huh?
I've had SI stuff.
Okay.
I threw it out while swinging one time.
But isn't throwing your back out not real? You learned that throwing your back out is not real.
We'll talk about it
Nicholas?
later. Alright. Okay, ready? Alright. Actually, no, let me do the whole thing from the beginning for those who are recording.
Yes, please.
You could do the this is for those. I always recommend that you guys could stop recording now.